Hello, welcome back. We are in Module 3 now, Statistical Process Controls Used in Performance Improvement. In this module, you will learn the methods that organizations use to improve the structures, processes, and outcomes of care. After an in-depth review of quality improvement as it relates to structure and process, I'm not going to go into a lot of depth on outcome because that's covered in everything. I will discuss how to identify and reduce errors, introduce the concept of never events, which I doubt I'm the first one to introduce, and if I am, believe me, you're going to hear it again. And then examine enterprise risk management as a method. Now, enterprise risk management is not a complete method without some of the necessary risk assessment tools. There are plenty of them, but the two that we're going to focus on are failure modes and effect analysis, or FMEA, and root cause analysis, RCA. Finally, I'll extol the virtue and importance of near-miss analysis, which frankly is a tool that I love because it looks at things that could have happened and gets in the way of them instead of looking at what already happened and how to stop it from happening again. It really is worthy of great discussion, even though it's something that's culturally not acceptable in healthcare. It's growing. It's usually used in aviation, and it took a long time to grow there, and in manufacture, which, frankly, it's still not heavily used in American manufacturing plants, except for those that have embraced Kaizen. So let's talk about structure and process improvement. We know that error can be individual. People or small groups can commit errors, and they can be the wholly responsible parties. However, that's not usually the case. What's usually the case is that error is systematic. For instance, you have a rapid response team cart. In that cart, you've got all these drugs, and right side by side are a lethal drug and an innocuous drug. The only difference between the two is that one's got a dark green cap, one's got a light green cap. Those types of things are systematic structural flaws that can cause error. And getting to how to get rid of those systematic flaws is really what performance improvement is all about. It's about incorporating all three of Don Abedian's quality domains: structure, process, and outcome. You'll get sick of Don Abedian and those three things before the semester is over if I'm doing my job properly. The Institute of Medicine has laid out 6 aims to guide performance improvement in healthcare. They are effectiveness, safety, patient-centeredness, timeliness, efficiency, and equity. The first 2 are pretty simple. It's a matter of looking at outcomes. Decreasing the number of patients that got influenza after they were vaccinated with the influenza vaccine means the vaccine's effective. An extremely small or 0 number of post-vaccination deaths means that it's safe. Simple. The other 4 present more of a challenge. And the reason they're more of a challenge is because they're structure and process oriented. The Leapfrog Group, which is an organization that purchases healthcare for Fortune 500 companies, has been working for several years to develop and validate structure and process measures to assess quality. The many measures they report and publish include prevention of errors using computerized provider order entry, CPOE, that's a process. Appropriateness of ICU staffing, which includes utilization of intensivists and ICU trained nurses, is a structure. Reduction of pressure ulcers, process, maybe structure a little bit. Reduction of central line infection death rates, or central line infection rates, I apologize, is definitely process. And to see how the hospitals near you kind of stack up, take a look at the link that I put on the transcript, because I was really surprised. Now, Rubin, Pronovost, and Diet, you're not required to read that, identified the primary advantages of process measures. Number 1, unambiguous identification of process deficits. What that means, well-developed and actionable process measures give program evaluators a clear indication of what went wrong and how it can be corrected. Outcome measures are different. They just tell you that something went wrong. You don't know what. Risk adjustment, number 2. Well-developed process measures risk adjust themselves because they define their eligibility criteria as part of the measure. So let me give you an example. In the vaccine example, if we wanted to improve the proportion of high-risk community-dwelling elderly receiving the vaccine by 10%, which is a process measure, the program developers would sit down and set the criteria for what is high risk and what is elderly, and then there's not much more risk adjustment that needs to be done. You can also add a structure measure in there to train the providers to select the appropriate people and get them into the program. Number 3, immediacy of evaluation. That's a process improvement program that requires that everyone meeting the criteria is included in the process. Unlike outcomes evaluations, in which the program evaluators have to call together considerable data over relatively long periods just to identify the very small proportion of people that had a bad outcome, evaluators can actually determine the effect of quality improvements for processes fairly quickly and with very little data because everybody gets the process. Rubin and colleagues also pointed out that there are disadvantages to process measures. Those include, number 1, lack of correlation between process and outcome. A process must have 3 things. It must have a logical, demonstrable or measurable, and published link to an outcome. Processes that lack all 3 of these linkages are inherently weak, and the process improvement could be challenging or even impossible to do. Expense of process measures is number 2. Some process measures might be necessary just to show organizational value or because administrators believe it to be sufficiently important to institute even if the linkages are weak. These measures could expose the organization to very high costs because the administrators tie the success of the organization to the success of the measure. And sometimes they just want to justify the cost of a given resource. Next is number 3, hard to sell to consumers. After acculturating healthcare consumers and payers to focus on outcomes for decades, it's really hard to sell them the ideas and associated costs behind process improvements. And 4, multiple processes represented in the care continuum. It is unlikely that one specific process is necessary and sufficient for one specific outcome. However, measuring multiple processes is challenging and expensive. Therefore, it's imperative that the process improvements are as comprehensive as possible and that they measure and document improvements very well. So let me give an example. Consider a case in which a nurse manager at a home care organization wants to decrease the number of hospital readmissions among diabetic patients. She proposes to do this by improving post-discharge diet education. There is a logical link between dietary knowledge and readmission. We know that. There's a link between dietary education and the associated increase in dietary knowledge among program recipients. That's demonstrable, it's measurable. You can give somebody a pre-test and say, what do you know? And give them a post-test and say, what do you know now? Finally, there are published studies showing that outpatients that are knowledgeable of their dietary restrictions and needs have lower hospital admission rates. Unfortunately for the nurse manager, there is more to readmission risk assessment than dietary education. Dietary education alone is neither sufficient nor necessary to prevent readmission. Therefore, if this is the only measure, it's going to fail. If she's attempting to justify the cost of a clinical educator, she might push this up to the administration. The administration, assume they like the idea, assume that they think it's a great idea, and they add some measures to make it really work. They're going to run into problems in selling it to payers and possibly even to patients. The reason is because it's kind of hard to market an idea like, we teach our patients to eat right. People don't care. We keep our patients out of the hospital. That they might care about. Now, Rubin and co-workers suggest that providers like process improvement projects if they're able to incorporate them into their daily routines, if they eliminate duplication of efforts, and give immediate feedback on progress. They also recommend quality improvement professionals show great care in choosing projects, choosing how to present evidence of the success or failure of the project, and requesting funding for process improvement initiatives. Since many of these initiatives do not show an immediate, easy relationship between cost savings and profits, promoters must carefully articulate the value of these projects to the stakeholders. That's it for this small segment, and I will see you next time.